Thank you, sir. At the outset, let me thank my good friend Bansi, Man, and Amit for inviting me and giving me this opportunity. It's quite interesting for me when I took up this topic because it's quite a new science which is developing in the field of diabetes. We all know that there is an exocrine pancreas and an endocrine pancreas, and we are more concentrated on endocrine pancreas because of the insulin, glucagon, etc. But exocrine pancreas is left behind, and much is not known about it, much is not done about it. And Off late, there are a lot of research coming in this area where it's not just about pancreatitis or pancreatic calculi which causes exocrine pancreas. Now, there are many research which is coming up in the field of type 1 and type 2 diabetes where exocrine pancreas is also involved, and whereby the release of exocrine pancreatic enzymes are deficient in these two diabetes, and which can lead to malabsorption, maldigestion, etc. So let us go into the evidence and a little bit detail into this. So exocrine pancreatic insufficiency has been reported now in diabetes. Awareness among diabetic care providers are low and contributes to under screening, under diagnosis, and under treatment. Prevalence is wide ranging in different studies. Type 1 about 25 to 75%, type 2 about 28 to 54%, it's as high as that. A long duration of disease, high insulin requirement, poor glycemic control may be contributing factors. But in type 1 and type 2, mostly it's in mild forms. That is why most of us have not been looking into this in the past years. Of course, despite this kind of high prevalence, which is now being noted, little is known about its clinical consequence of this and its optimum treatment. Even less is known if and to what extent exocrine pancreatic insufficiency also affect the glycemic control. Understanding the necessity of improved diagnostic tests and algorithms are needed in the future. Now, this is a recent paper which was published in ADA 2003, and when you look at the data, you can see that the exocrine pancreatic deficiency in type 1 is about 33%, and type 2 diabetes about 29%. It's very high, and many a times it's often, underdiagnosed. Maybe because now diabetes is coming at a younger age and a longer duration of diabetes, maybe it is affecting the exocrine area of the pancreas as well, which was never looked into or even neglected. So, uh, in other pancreatic, we all know about the chronic pancreatitis, calcific pancreatitis, and others, where it's a severe disease, and then you have steatoria, weight loss, etc. But in type 1 and type 2, it's not as severe and is mild form. So, most of the time, it's just abdominal discomfort or flatulence or diarrhea, etc. And so, many a times, it's overlooked as some causes of drug induced, like metformin or IBS, etc. In a meta-analysis of 17 studies in 3,662 subjects, the fecal elastase 1 concentration was reported in 38. Lower than 200 is considered to be insufficiency, and it was present about 38% and 28% with type 2. Hardit and colleagues reported that fecal elastase concentration in 40% of diabetes with long-standing diabetes. That means as diabetes is increasing, the incidence is going higher. 12% of patients with diabetes diagnosed with this was defined with very minimal lower levels of fecal elastase 1. Now, 25 that the vitamin D deficiency was found in some of these patients with low fecal elastase. Another study also showed sarcopenia in these patients. In a very recent population-based study, a close relationship with this also was found with the gut dysbiosis or gut access gut exocrine pancreas axis also has now been looked into. This is a recent study done by our good friend Shashank Joshi from India, the prevalence of pancreatic insufficiency in patients with diabetes. And the conclusion is about one-fourth of the patients, Indian patients, have this, and many times we still are not looking into it. And the longer the duration, poor the glycemic control and obese these people have. And the results of the study highlights the need for active monitoring of this, and especially for those with long duration of diabetes, poor glycemic control, and gastrointestinal symptoms, and which may be in the long run be benefiting the overall quality of life. So this is just a algorithm. Suppose you have mild to moderate or severe symptoms after excluding the causes, other causes, then consider imaging and also do a fecal elastase test, which is the easiest test. If it's below 200, then it's mild, and you can think of there is an insufficiency and look into other dietary and replacement therapies, etc. The pathophysiology is not clear yet in diabetes, but then there are suggestions that could be due to trophic effects, diminished trophic effects of insulin, inflammation, fibrosis, and steatosis. And also diabetic microangiopathy and impaired neuropathy, autonomic neuropathy, all could be contributing to this effect on the exocrine pancreas. Other contributing factors with time as pancreas in type 1 and type 2 gets atrophic and exocrine function also may be declining. Immunological effects, CD8, CD4, all this could be contributing in type 1 as well as type 2. And also the stellate cells may be affected and pancreatic fibrosis may be present. Fat accumulation in type 2 may be present. So fibrosis and steatosis, a meta-analysis found that 59% of the patient either with type 1 and type 2 shows histological signs of fibrosis in these patients. And the stellate cells could be the crucial drivers for this fibrosis. Also, cytokines and platelet-derived growth factors also could be contributing to the increased collagen production and fibrosis, which could be also associated with ectopic fat deposition in these exocrine area of the pancreas. Another theory is that there could be also inflammatory pathology to this, and of course I don't want to go into the details because these are all the newer signs which is developing and which is causing these kind of exocrine pancreatic insufficiency, which is leading to all gastric symptoms and also vitamin deficiency like A, D, E, K can be affected, and also sarcopenia, as I was mentioning. So this is just to give you a highlight the immunological effect, the ectopic fat deposition, the fibrosis, and the crosstalk between the exocrine and the endocrine cells, which could lead to this kind of the decreased trophic effect of insulin, could also be contributing to the exocrine insufficiency in pancreas and diabetic patients, type 1 as well as type 2. Now, this is another study which was published in Diabetes 2024, the exocrine pancreas in type 1 and type 2. And they studied from donors and they did a histological analysis, and they found that in type 1, it was more to do with acinar atrophy, ductal and vascular fibrosis and angiopathy, and less with adiposity, whereas in type 2, it was more to do with acinar and ductal metaplasia and lobular fibrosis and angiopathy. Whereas the total fibrosis was increased in both type 1 and type 2. So to conclude, the diagnostic approach, as I've said, there are various tests available, but now all these tests are very laborious and not practical. So they've come to fecal elastase 1, and below 200, it is insufficiency. Below 100, it is severe. But in type 1 and type 2 diabetes, below 200 itself is diagnostic of insufficiency, and it is now available in India. And I think it's time that we all start checking in our clinical practice. Now, coming to therapy, of course, there are not much data, not much evidence to say that there is the definitive treatment. But then Definitely, low fat diet, low high fiber diet has to be done. And of course, we can try. There are one paper study where I saw that they tried with this pancreatic replacement in a smaller dose, and they found that glucose control also. So, well, this is a new area of research, and I'm sure in the coming years we are going to have more data on this, and we'll be better off in treating our patients in this aspect of diabetes. So, to conclude, my dear friends, this is a new emerging problem in diabetic patients, the exocrine pancreatic insufficiency. The symptoms are usually mild, so don't neglect it. And as I said, fibrosis, inflammation, and steatosis in exocrine pancreas leads to the deficiency or the insufficiency of the enzymes which it secretes, which leads to malabsorption and maldigestion in your patients, which can lead to deficiencies like ADEK or sarcopenia. And ideally, optimal treatment. Definite um, data is not there in the treatment, but then of course we can try the replacement therapy. So in conclusion, although highly prevalence is there, in both type 1 and type 2, diabetes remains a poorly understood disease. The exocrine insufficiency is poorly understood disease of unclear clinical long-term significance. And I'm sure that in the future we will get more information on this, and I'm sure that this is going to change our practice in a big way and definitely improve the clinical outcomes and the quality of life in our patients. Thank you. Thank you, one and all.